Hi, Smart News. We're going to do something this Friday that always feels good. We're going to take a deep breath and take a look at the headlines. And we're going to take that deep breath with a pulmonologist, which is ideal because Dr. Rutland is a pulmonologist that has actually treated COVID-19 patients. And we had a flurry of activity really over the last several days in the news talking about immunity, COVID-19, what we're learning, vaccinations. And in order to kind of work through a couple of these different studies and what we're seeing, I thought this is the perfect moment for Dr. Rutland to join us again to just kind of dissect, pull apart what we now know or are now learning as this story continues to develop. You know how I am. I always feel like we have to add a little asterisk because we're still in a developing story of a pandemic, a historic pandemic. What we will learn may take a while. And we're kind of learning some things, then taking a couple steps back, going forward and going back. And so we always have to preface these conversations with, this is what we now think we know and that we're going to build from. So let me go ahead and see if I can pull Dr. Rutland in. Here we go. I always feel like Instagram should have some like music for you when you're doing this in the background. Appropriately transition. So I'm curious what questions you guys have. I have a bunch of them from you.
It totally should have some music.
What? Thank you, Dr. Rutland. There you are.
I'm
Okay.
coming in. I didn't know if I was supposed to start in my shoe closet or not.
I
did.
was going to do that. I was going to make that special request. Maybe we can still take a field trip if we need to, kind of mid-conversation as an
Sure.
interlude, you know? Because for people that don't know, Dr. Rutland has actually the most impressive shoe collection of anyone that I've ever seen.
I don't know if it's that impressive.
Okay,
But
how many
it's
shoes
up
do you
there.
how many pairs of Nike shoes do you own?
I don't know, maybe 200 or 300, something like that. I don't know, something like that. A lot.
Dr. Rutland. How did that like hobby start? What was the beginning of that?
You know, it's actually kind of fun. It was neighbors growing up was Raphael Sadiq, who was the lead singer in the group called Tony, Tony, Tony. You
Right?
remember that song? Do you
Of
know what
course.
today is? It's our
Yes.
anniversary. So he was my next door neighbor, and he lived in a modest house in Sacramento. And he's like my uncle. I actually literally was talking to him 10 minutes ago. We were talking about the entertainment business and all the stuff and the TV show that I'm doing. And anyway, whatever. We were talking about a whole bunch of stuff because he helps me with that stuff. But he got me started, and this is how it started. I was a freshman in high school, and I played basketball. And I was pretty good. And he said to me, every time you score 20, I'm going to buy you a new pair of shoes. And I was like, all right, cool. And I scored 20 all the time. So he ended up buying me shoes like all the time. And finally, he was like, I can't afford this.
And that was it.
And that was it.
Do you still have some of those? Because some of those can be pretty valuable. I'm not saying you're old. I'm just saying, there could be vintage is what I'm saying at this point.
So, Nike does a lot of retro releases.
Yes.
And so, yes, I rebought some of the ones that he originally bought me. Yeah.
Oh my gosh. Look at that. All right. Well, I am getting so Lainey really would like to see your shoe closet. So
I will do that. You want me to do it now?
Okay.
Should I just knock it out and just get it done?
I think we should. I mean, should we go, guys? Let's just go
We'll just
because
go
we're going to have
upstairs.
every other conversation we're going to have about COVID is going to be exactly the same. We're going to see exactly the same on the news.
You guys get like a little tour of my house.
I also think it's a good time, Dr. Rutland, as you're walking up there to remind us about why you became a doctor, because you really have a passion for medicine and science, and you're a father of two. What is it about medicine that brought you to it? And then we're going to see your shoes as soon as you get there.
So what is it about that brought me to medicine was I wrote it down when I was 10 years old that I wanted to be a physician. I went to Catholic school my whole life. Sister Ann made us write down 2 short-term goals, 2 long-term goals. And of course, my short-term goals were like get straight A's and score 20 in my next basketball game. And my 2 long-term goals were get a scholarship to North Carolina or Georgetown and go to the NBA or go to medical school, become a doctor. So I put that on my grandparents' refrigerator, and it was there for like ever. I went to college. My grandparents had respiratory illnesses. My grandma had a trach. From a botched thyroid goiter surgery that she couldn't get because she was Black, living in the South.
And a trach is, can you remind us of what that looks like?
Tracheostomy is where you put like a hole in the neck here to be able to breathe.
Mm-hmm.
And basically what happens is your vocal cords, they open and close, right? So when you cough, your vocal cords are closed and they push this air down because your lungs are irritated. And what happened is, where the thyroid is located, there are nerves that innervate the vocal cords. And so when you take out a goiter, you have to be very careful because you can actually snip the recurrent laryngeal nerve. And what happened to grandma was they snipped the recurrent laryngeal nerve, and she had a hoarse voice for a long time. And then she was pregnant with twins. One of those twins happened to be my mom. And she couldn't take deep breaths. She couldn't breathe. And so they put a trach in. And after she had the kids, she said, just leave it. I can breathe so much better. And my grandmother had virtually an untreated trach for 65 years. She died at like 95. Yeah. And so she would cough every morning, every night. And so it's so funny whenever I see patients with trachs and they're complaining to me about cough, I'm like, dude, my grandma had one for 65 years. You're going to cough. Like, there's nothing you can do about that. Like, it's just how it is. So that kind of prompted me and pushed me towards the lungs. And my grandfather smoked every day for a while and then quit, but he had emphysema, which is dead lung. And so that prompted me as well. That's my wife.
Hi, Dory. It's Dory, right? Is it Dory?
Yeah, Dory.
I feel like I know her from social media. I'm like, hi, Dory. How you doing? You look great.
Like she knows you from social media. She said you look good. She's about to get on the Peloton.
Okay, good. I hope she's actually going to be working out with my instructors that I like instead of the ones that you like, which is another conversation.
Who are you doing today? Who are you doing on the Peloton today?
I'm actually going for a walk. It's so beautiful.
Okay,
she's going for a walk. It's beautiful. So here's this.
Yeah, let me see. Wait, what does Dory think of your sneaker collection?
Here, she's right here. I'll put her on.
Yeah, I need some like.
They want to know what you think of the sneaker collection.
We really want the truth. We feel
video?
You're 100% on Instagram Live. You look great. It's okay. I'm not going to interrupt your walk because as a mom, I know how much you need it. Like we need to get you out the door.
That's so nice.
But
what do I think about the sneaker closet? I think my thoughts have evolved over time. I think initially I was super annoyed and really upset that it's taking up our closet space. But
but then I bought her these, and she was excited.
Okay, all right.
No, it's not. It has nothing to do with that, really. I do like the shoes, but no. I mean, I think it's cool now, and I'm kind of excited to.
What are you doing with it?
Do the sneaker office so they can get out of the closet.
And then we can have him as a background for all of his Instagram lives. I feel like I'm seeing like a whole thing here. Yep. All right. Yep. Thank you for that. I appreciate that firsthand perspective.
Here's this is my closet right here. You see that? And then he gets the rest. So
that's it. Dr. Rutland, we're gonna have to discuss that. I think there's something a little uneven about that.
The sneakers are leaving in when is the guy coming next week? The guy is building our sneaker closet next week and building our desks for the kids. We're gonna have a built-in desks so they can do their homework. He's building that all next week.
Okay. Well, we look forward to watching the progress on that. Thank you to your wife for the perspective. That's very invaluable to have a firsthand perspective so we can double source what's happening.
Double source.
Yes. Okay. All right, Dr. Rutland, just show us, bye, Dory. Show us your favorite pair.
I'll show you. Okay. So this is one of my favorite pairs. You guys are going to enjoy these.
Okay.
So these are off-white Prestos. They were all white, and I had my guy tie-dye them.
Very cool. Okay. So do you have a most valuable pair?
Let's see. This pair is probably worth the most. Let's see which pairs. Oh, yeah, probably. So these are Dior's.
Let me see.
Dior Jordan 1, these here.
So those are the original.
Yeah.
Very good. Okay, look at Lainey's enjoying this. Nancy's enjoying this. Everyone, I think you've earned credibility as a shoe guy, which is important. And I'm getting some great questions too, which is giving me some time to write them all down. Just so everyone knows, when you do send us questions on Instagram, I also print them out like this so that I can pull them up and actually ask the doctor what you're sending in. So when you do message us, it's not just for I'm just asking you to go through an exercise. Yeah.
I want to remind everybody, listen, when you guys ask these questions, if you guys are asking specific statistical questions, which I do appreciate, and I will answer, understand that I'm a practical man. So I'm going to answer practically. I'm going to say, listen, this is practically speaking what you should do or what this means. I'm not going to say, oh, well, according to the stats, 1% of people, like, I think that kind of an answer doesn't really give you an answer. It gives you a number. So I just want you guys to know that.
Well, I think during an uncertain time, we kind of pull into statistics because we feel like the numbers give us some sort of security. Like we can say, oh, well, the percentage of getting really seriously ill is this. And although the percentage can be accurate, it also may not apply directly to our lives depending on our circumstance. But in this kind of chaotic moment, we're all looking at things that we can hold on to as facts. Is there anything else you want to show us, Dr. Rutland? I mean, you're a practical man with 300 shoes.
I'll show you one other pair that you guys will appreciate.
Okay.
So Kobe Bryant has these shoes called the Grinches. And so I have a couple of pairs. I have a pair of Grinches that have remained green, and then I got a pair like painted on. So like these are the Grinches, and then my guy did a Grinch.
Who is this guy? Like, is this a thing that you can bring shoes to and get them painted? Like, is that like a whole profession that I need to know about? I don't know anything about that.
So he is Sir Castletees. He's on Instagram at Sir Castletees. He's got a shoe store in Raleigh, North Carolina.
Okay.
And he is an amazing creative man who makes a boatload off of painting sneakers, coloring them, and selling sneakers. And so he has all of the latest releases, and sometimes I buy the original latest releases from him. But he also does creative things. And as a creative person myself, I have him do creative things to my shoes. Like, here's another pair he's done for me. He took like my.
How much did that cost to do?
This was like $100. This is like nothing.
Okay.
The Prestos he did were probably a little bit more, maybe a couple $100, because it's a little bit harder. So yeah. That's what he does, and I've had him do it a number of times. I mean, I got a bunch of shoes in here. I mean,
okay, I'm gonna have to tag him. Okay, well that's good. So everyone has hobbies,
Everybody has hobbies.
That's it. We got a little taste of yours. This is what you roll into the hospital with your Nikes on, and you treat people for all sorts of reasons, Dr. Rutland, but mainly obviously focused on the lungs. And that was actually a great question that we just got on our feed, which is whether or not we're still appropriately positioning COVID-19 as a respiratory illness. What do you think about that?
Yeah, it's a respiratory illness. In fact, it's so much of a respiratory illness that I didn't take a lot of issue, but I just felt like, pulmonologists needed to be the people who were speaking. I'm putting my contacts in because when I go back down to my ring light, I don't like the glare.
Fair point. Okay.
So I felt like pulmonologists should be doing most of the speaking, but then I realized that, they're doing most of the caring. They're in the ICU. We're in the ICU. We're busy. So that's why, we weren't talking as much. But it's definitely clearly a respiratory illness because that's where it enters the body, is in the respiratory tract almost 90% of the time.
How has your treatment of COVID changed from last year at this time to now? Do you feel as a physician that you're able to more appropriately treat COVID-19 patients, or more, ethically, like efficaciously? Yes.
I think that we know sort of how not to make things worse.
Mm-hmm.
We know not to intubate people and give them a high amount of pressure on the ventilator, which leads to, worsening of the inflammatory process. We know how to immunomodulate people, calm down the immune system, because most people look at SARS-CoV-2, which causes the disease COVID-19, as this gnarly infection, right? And it's really not that it's acting like an infection, it's more so acting like an autoimmune disease. And so fully understanding that and people really accepting that finally led to people really using medicines that calm the immune system down more than trying to use medicines that effectively limited the replication of the virus. So do I feel like we treated better? Yeah, but I mean, if you ask people who kind of paid attention to this stuff from the very beginning, like we've probably been treating it the same way the whole time.
So there hasn't necessarily been, in your mind, a blockbuster therapeutic that is completely changing the way you're treating someone that's coming in with like a moderate case of COVID.
There is a blockbuster therapeutic, but it's just not advertised like it should be, if you really want to know.
Why is that? What is it?
So for me, I think the blockbuster therapeutics are monoclonal antibodies. So the way that the virus has worked and the way that the virus binds to our own cells is it uses the spike protein, right? And it uses the spike protein to bind to the ACE2R receptor, which is heavily abundant on small intestine cells, and it's also abundant on the airway epithelial cells. So because we know that, right? We knew it from the SARS-CoV-1 epidemic in China. Because we know that, we were able to create antibodies that bound to the receptor binding domain of the spike protein, not allowing that virus to bind to our cells, right? But the tricky part was knowing when people were actually infected, because we know that the viral load is what contributes the most to the severity of illness. So the higher amount of virus that you're exposed to, the more severe your disease. That's why nurses were dying and physicians were dying in Italy and in New York, because they were just really exposed to these high viral loads. So the monoclonal antibodies do is they prevent those viral particles from binding to the cells, so you don't get that insanely activation of the immune system that gets recruited to the lung, which causes the clogging of all the balloons in the lung and causes you to be short of breath and cough and develop pneumonia. And so these monoclonal antibodies prevent that from happening. And so if you get the monoclonal antibody soon enough, it's really effective. It prevents hospitalizations, probably prevents mortality as well. So the problem is like, well, when do you know? And so what I would have done differently is instead of, and I heard this all the time, and the reason why I'm saying this is because this is what my patients were told when they went to the hospital, is they would go to the hospital and they would say, oh, you're not sick enough, just go on home and take care of yourself, right?
Right.
Even though they were positive. That's actually an opportunity to give the monoclonal antibody. You don't want to give it to somebody that's sick because they're already sick. The process is already taking place.
The immune reaction is already happening that could eventually bloom to a point where the body is getting overwhelmed.
Exactly. And so doctors who were responsible for prescribing this medicine weren't really used to the mechanism of this medicine and what they were actually doing. A lot of physicians, I'm not making fun of physicians, okay? I think physicians were all great, but a lot of physicians think about reactive processes. You get this, we give that, which is the wrong way to think about it, because disease is constantly evolving and constantly going, right? And so as the disease constantly moves and develops, you're just going to increase the severity of disease. By the time it shows itself, it may be too late to reverse it. And in situations like COVID-19, that's what was happening, is by the time it showed itself and you saw COVID-19, people were really sick. And there was really nothing you were going to give them that was going to reverse it. And the problem, I think, was that everybody kept calling it COVID. Oh, I was positive for COVID. That created a huge mistake in my mind, because it kind of, it almost, what's the word I'm thinking of? It combined, unified this concept of having a SARS-CoV-2 infection and having COVID-19 like it's the same thing. It's not. For me, early SARS-CoV-2 infection, you come into the hospital, your husband had it, let's say, and you come into the hospital and say, hey, my husband was just diagnosed with SARS-CoV-2 and COVID and is coughing and really short of breath at home. I don't have any symptoms yet. When you come into my ER, I can give you this monoclonal antibody. And I think that would prevent some of the consequences of the presence of the virus, because I'm giving it to you early before you have symptoms. But some people were just saying, oh, you're not having symptoms, go home. I didn't like that. I didn't think that was the right thing to do. I never did.
But are those monoclonal antibodies available on any sort of a level now where that scenario, and is it available for some, let's use that scenario. Let's say my husband gets ill. I say, hey, in our household, I'm worried. I got 3 little kids. I'm not feeling great, but I'm fine. I'm walking around. I go into a physician. I'm otherwise healthy. Would they actually even give me something like that at this point because I'm not in a high risk category.
They wouldn't.
Mm-hmm.
And
Right.
I think that's wrong.
Mm-hmm.
So they came up with these ridiculous rules of, well, you have to be 65 and you have to have diabetes. They were just coming up with all these risk factors because of the supply, you know, and they didn't want the ER to be bombarded with patients that had SARS-CoV-2 infection. So they were coming up with all these ridiculous rules that there's really no evidence for these rules. They just kind of made them up. And I didn't like that because it just showed a lack of creativity for an illness that was quite frankly killing people, and we didn't know who it was going to kill.
Okay, so questions. Yeah. Let me ask you there for a second because we're getting a lot of questions, and I've had these questions periodically over the last several months. Speaking of creativity and using things that are available, there are those that have, you know, brought up, you know, drugs that have been used for years. One of them that's gotten some attention, especially overseas, is ivermectin.
Right.
What are your thoughts on ivermectin? We're getting a lot of questions about the efficacy of that or whether or not that should be used. What should we know about it?
So, you know, it's interesting. Whenever you look at drugs, you want to understand the science of them and the mechanism of them. And again, you guys all know that I would speak a lot on COVID. And one of the things that I really tried to do was really understand the therapies and how they interact. And I'm pulling up my slides because I just want to be 100% correct. You know, the way that ivermectin was actually working was it wasn't allowing one of the non-structural proteins of SARS-CoV-2 to have its antiviral activity, we think. That's what we think the mechanism was. So, or to have its viral activity. And so when you had it around, it couldn't have this viral activity. So we actually studied it, right? And we did randomized trials. We gave patients ivermectin early and late. And it turns out that actually with that medicine, that medication, it didn't really alter the consequences of the infection. So the people that were getting better were people that were getting better just because their immune system was doing what it was supposed to do. So it wasn't really an effect of the medication.
So
now,
yeah.
Go ahead.
No. But we keep on hearing about it, you know? And so is that just because people are like, hey, it doesn't hurt you. If it doesn't hurt you and we're seeing something, maybe the data is showing us this, well, you know, we don't have any sort of real medicine that's treating COVID right now. Is that the perspective that doctors are taking it? Hey, this is a relatively cheap drug. We don't really think in these clinical trials it's necessarily doing anything, but
when you look under the microscope, it did reduce virus concentration, right? So when you look under the microscope at the cells that are infected by SARS-CoV-2, like you can see that it reduced the virus concentration in those groups of cells, right?
Okay.
But in vivo, like it didn't seem to have that clinical effect that we wanted. But you're right. There are certain medications we may give, even though we think that they don't work, like antibiotics in the wintertime, right? People come in, they have the sniffles, they're like, hey, I need a Z-Pack, and we give it. It's not like there's any evidence for it, but we give it and the patient feels better and they kind of grow this attachment towards it. So a lot of people have said, hey, you know, look at India, all these cases are turning around. Well, I mean, if you're going to say all these cases are turning around with ivermectin, we already know that 99% of people live that have SARS-CoV-2 infection, right? 99% of them live and they do just fine. I think the way that I would kind of look at that really is the people that got ivermectin, are they still getting post-COVID syndrome at the same rate that the people who didn't get ivermectin are? That's how I would kind of look at it.
Oh, interesting. So look at kind of like the long-term impact and see then are we seeing something? Maybe we don't necessarily see something in that it like, you know, cures people, but that maybe there is something there that we still need to take a look at. So you're not in the camp of like, oh yeah, let's just cross that off the list. Because that's the conversation that a lot of people have heard over the last year about anything. Hydroxychloroquine was one of them and ivermectin's one of them. I'm sure our viewers can write me any number of different treatments that they've heard about. And quite frankly, as a journalist, it's been difficult at times because, you know, you'll get people will instantly say, absolutely not. There's no way that any of that stuff works. And then you'll talk to people that are actually treating COVID patients and say, well, you know, it depends on when you give them this medicine. And we're going to try a couple things and we actually don't really know. So and that's tough if one of the big things that every family is facing is potentially this deadly virus that could alter someone's life, so that's been really difficult to navigate.
Yeah, when you look, if you go back to November or October, whenever Trump got SARS-CoV-2 infection and COVID-19, and he started to develop symptoms of SARS-CoV-2, like, what happened? Well, he went to the White House hospital and then eventually got checked into the hospital where everybody goes out there.
Right.
And he received casirivimab, imdivimab, which are Regeneron-CoV-2 monoclonal antibodies. He received prednisone. He received Plaquenil. He received aspirin. So he received all of these therapies up front. And people were making fun of him for it, saying these therapies had no evidence and blah, 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 blah. And I just saw genius. I was like, yeah, that's what I would do, right? If I was the end-all be-all at my hospital and I got to make those decisions, it's precisely what I would do. And I would do it for everybody. And the reason is because I believe in those therapies. I believe in the monoclonal antibodies specifically. And I think that they're extremely underutilized.
But they're infusions, right? They're infusions into your arm. So they're not necessarily like Tamiflu that you got diagnosed with the flu and you get it and it's supposed to shorten your symptoms. This is something that you would have to be under care to receive at this time.
Yeah, but I give monoclonal antibodies all the time. And so what's going to happen is in about, I don't know, maybe a month or two, Regeneron-CoV-2 is coming out with their sub-Q product, sub-Q monoclonal antibodies. So it's the monoclonal antibodies and you just inject it in your arm. It's just a shot. So there are monoclonal antibodies that I give for asthmatics, right, that have severe asthma and have a certain immune cell associated with it, or they have certain other clinical characteristics, like they require oral corticosteroids. And I give a sub-Q injection. They get it every 2 weeks. They give it to themselves at home and they're fine. So I'm used to prescribing those medicines. I'm used to side effects of those medicines. I'm used to patients being on them. So obviously, if I'm used to it, I should be the population of physician that you go after because I prescribe it all the time. But when you have a new medicine like monoclonal antibodies and you ask, physicians in the ER to give it, they're not used to giving these therapies. They don't know what to do if something happens or if somebody has anaphylaxis, which can happen. It rarely happens, less than 1% of the time, but they don't know what to do. So they're going to find every excuse in the book not to give it. And that's what was happening across the country. And so I just felt like the strategy was just wrong.
But was it available for them to use? Was it available?
Bamlanivimab and Regeneron-CoV-2 have been available for them to use since like October. And then there was a new GSK product, God, what is it? Samiluvimab or something like that. Anyway, whatever. That was just released for FDA emergency use authorization like last Friday.
So you're saying this is the trend that we should know about. The trend is moving towards these monoclonal antibodies, an actual treatment that for even people that have mild symptoms. And maybe this is something that we should just be aware of because it could be potentially over the next year, as we're talking to our own physicians, something that they suggest or something we should ask about.
So this is a therapy that you should use if you haven't been vaccinated and you're heavily exposed to somebody that has SARS-CoV-2, even if you're asymptomatic. The whole point is to not be symptomatic. Every physician is taught to be reactive. Have this disease, give this therapy. But what people don't think about enough is the evolution of disease. It takes time for those cells to lead to the physical manifestations of illness. And the way that cells talk to one another is through these molecules called cytokines and chemokines. Cytokines are essentially phone calls that cells make to other cells in a distant way. Example, when your airway is annoyed and it's worried about a molecule it's exposed to, it could be a virus, a bacteria, pollen, you are going to secrete certain cytokines. These cytokines are going to have an effect on white blood cells distally and call them over. You also secrete local chemokines. Chemokines are molecules that have an effect on your blood vessels and on your lymph tissue to open up the bridges in between your cells so the cells aren't so tightly bound together. You open up a bridge and allow cells to kind of roll into an area. This is disease. This is how disease starts. All of the products or all of the results from the presence of these cytokines and chemokines lead to physical manifestations of illness. And what these monoclonal antibodies do is they don't allow the binding of a certain process, of a certain protein to take place. So you don't get the results of disease. And so you're affecting disease so the consequences don't take place. And the problem, which I completely understand, is you don't know who's going to go there and who's not, and so you worry about the cost, which I completely understand. But when you don't know that, it doesn't mean you don't do it. It means you give it to people even if they're healthy and walking around. Who cares? You're trying to prevent the spread of disease. What I would have done in a perfect world, the Rutland perfect world, right? Let's say that everybody has the Rutland room. Like if you came into the Rutland room, what I would have done is I would have gone to the areas in which people weren't vaccinated. I would have given them all monoclonal antibodies, which last a few weeks, a couple of weeks, right? Floating around the bloodstream, preventing infection. And I would have vaccinated people, right? Because what are you doing with vaccination? You're stimulating the production of antibodies. And you're stimulating the production of B cells and T cells and dendritic cells and NK cells to recognize infection. You're treating them to recognize the virus's presence. That's all a vaccination is recognizing the presence of the virus so your immune system isn't surprised. That's all it is. You don't want your immune system to be surprised, because when your immune system's surprised, that's when disease happens.
And it goes boom, right? It's surprised and it reacts.
Yeah.
So this gets to the heart of our conversation, which is how we started talking again this week about this, which is there's obviously a press to vaccinate a lot of people. That's been the position of the U.S. government. And there have been, a fair amount of Americans that have made that choice. Mm-hmm. Then you have a fair amount of Americans who say this is not the choice that they're going to make for their families. And then you have some people that are in between. This is what's getting some attention, which is those that had COVID-19 infections. And by the way, there's more than 30 million Americans who have tested positive for COVID. We think that asymptomatic spread could be 5 times that. So that could be half the country that had some sort of exposure to COVID. And now we have about half the country that over 12 that's vaccinated. So there seems to be this pitting of like vaccinated people against unvaccinated people. But we have to look at unvaccinated people as some that had infections that are not necessarily jumping and getting the vaccine right away. The question is right now, how does the immunity of someone with the vaccine differ from someone with the immunity of having a COVID-19 infection?
The SARS-CoV-2 infection.
Yes, thank you. We'll use it. The SARS infection, not the COVID-19 disease, which is important, by the way, as Dr. Rutland points out, because if you're positive for SARS-CoV-2, it doesn't necessarily mean you're going to get the disease of COVID-19. Because if you're asymptomatic, then you technically don't have COVID-19, because COVID-19, coronavirus disease 2019, is the name of the disease, not the virus.
Right, exactly. So here's the difference. And everybody has to have a little bit of an imagination here. So when you are infected with SARS-CoV-2, SARS-CoV-2 is a entire virus molecule, right? So what you have is, I know. So
thank you.
Yeah.
This brings it down a notch. By the way, we should just do this for all coronavirus conversations. Just have a dog, and it'll make us all feel like a little bit more. There we go. Okay, sorry. Please go ahead, Dr. Rutland and Puppy.
So, it's an RNA virus. It's got 4 structural proteins on the outside of it, right? Nucleocapsid, membranous, envelope, spike. Then it codes for 16 non-structural proteins. It's got some open reading frames on the inside. It's an entire molecule. So when you're infected with this entire molecule, your body basically breaks up this entire molecule. There you go. And it turns it into little pieces, and your immune system recognizes different pieces of this virus, right? So it creates antibodies in cells to recognize the membranous protein, the nucleocapsid protein, the spike, the envelope protein, in addition to some of the open reading frames of the virus on the inside.
Okay, can I pause you there? Let me just pause you there for a second. So would that be like instead of recognizing a person, you're like, oh, I recognize that person's eyes. I recognize that person's nose, even if I don't recognize the person overall. Is that how our bodies are sort of?
Or recognize that person's shoes.
Right. Right. So, for example, so you're kind of recognizing pieces of the virus all the time, not necessarily the virus totality as one unit.
Once the immune system has done its job, yes.
Okay.
Now, as you're infected with the virus, right, and your immune system is doing that, while simultaneously the virus is replicating in other cells. So you're calling on the immune system to do a shit ton, right? So it's doing a lot. So not only is it trying to prevent the infection of other cells and getting called over, but it's also trying to do its thing and create immunity and develop all this stuff. And it tends to do that in the presence of end organs like the lung, because the virus is a respiratory virus. So when that happens, what happens to your lung? Your lungs get clogged up, and you cough, and you become short of breath, and you see me in the ICU. So that's how your immune system works, right? So Elio Diva has a good question, so we'll get to that. But anyway, that's how your immune system works. That's how you create immunity to the virus. So if you look at the immunity for people that have been infected, they have a lot more different types of antibodies towards many different types of structural proteins. Okay. When you get the vaccine, and the vaccine right now, the vaccine is just exposing your immune system to the spike protein.
Okay.
Just the spike.
I'm with you now.
Right? mRNA vaccine encodes for the spike. So what happens is, look at the mRNA vaccines. Here's what happens. When you inject the mRNA vaccine, the mRNA gets inside your cell and gets immediately translated into protein. It becomes the spike protein, all right? It doesn't mess with your genetic code in any way, shape, or form. So that discussion needs to stop. So it gets immediately turned into the spike protein. Your body understands that the spike protein is formed, right, on the inside. And so it cuts it up into little pieces on the inside. And then these little pieces of the spike protein get displayed to the immune system. The white blood cells come over and they look at it and they're like, oh, okay, this is that piece. This is the backwards piece. This is the middle piece. This is the top piece. This is that side. This is that side. So it creates a diverse array of immune cells that recognize many different aspects of the spike protein. That's how a vaccine works. Not only that, but where are you injecting the vaccine? In your shoulder. So where's the immunity taking place? In your shoulder. It's not taking place in your lung. It's not taking place in your end organ. It's not clogging up your lung. It's just causing pain and sometimes rash in your arm, because that's where your immune system is being recruited. I don't give a shit if immunity is taking place in my shoulder. I'd rather have it take place in my shoulder than in my lung, right? Because my lung is an end organ.
Right.
My shoulder is just my shoulder. Nobody's shoulder is falling off. Nobody's lost a shoulder because of the vaccine. But that's how the vaccine works, okay? And so what you're doing is you're creating a diverse number of cells that recognize many different aspects of the spike protein. That's why the vaccine works for the variants, right? And everybody was tripping about the variants of concern.
Yes.
And if you look at what I had mentioned before, and all my friends got mad at me, I was like, the vaccine's going to work on variants. I don't care. And it does, right? It does, right? It works very well.
Because every variant has a spike protein.
A different spike protein.
A different spike protein.
Yeah, so all proteins are made up of amino acids that are stacked on top of one another, like bricks of a house, right? If you look at bricks, you got amino acids, you got one brick, you got cement, which is the binding, and then you got another brick, right? So those are different amino acids, okay? So if you have a yellow brick, a black brick, a purple brick, a red brick, those are different amino acids, okay? So variants of concern have different amino acids in areas of the spike protein, like in the area of the spike protein that binds to our cell, the receptor binding domain. So you might have, instead of a yellow, black, red, gold, you might have black, red, gold, yellow, right? So so it looks different, and three-dimensionally, it's going to look different to the immune system. So everybody's like, oh my God, the immune system's not going to recognize it. Slow down, because the immune system creates many different versions of what it can look like when it's recognizing this.
Got it. So, okay, so let's bring it. So that's what the mRNA vaccine is doing now. But you said that with such emphasis. Do you believe a different vaccine later will do something different, or do you think this is the effective vaccine for this sort of coronavirus?
Yeah. So there's going to be there'll be inactivated SARS-CoV viral particles, right, where you create immunity to the entire virus. They just want to inactivate it, but the virus is so dangerous right now that nobody wants to kind of do it yet. We've done it, and they're in trials. And I'm sure a vaccine like that will come out. And it's a more traditional vaccine, like an inactivated influenza or inactivated SARS-CoV-2 vaccine will come out, I'm sure. But yes, this was just a new strategy, but it was a strategy that was created years ago. We never really knew if it was going to be super effective like it is, but it just turns out that this is the most effective therapy in the history of the world. And so now people are going to say things like, oh,
do we have to say so far? Because we're seeing people get the vaccine. We've only seen it really over, I mean, I was looking back, the first time someone got a vaccine that wasn't in a trial in America was mid-December.
Right.
So now it's only 6 months. So like, can we say that, or do we have to say so far? Is there any reason to believe that in, 12 months from now, it's going to look different?
No, I don't think it's going to look different. And I don't say so far because over 2 billion people have received the vaccine. I mean, that's the most that any medicine has ever been given to anyone in the history of everdom, right?
So that's just about 1 in 4 people on the planet have received it. So it's a huge amount of people, right? I mean, that's a lot.
Huge amount of people. And people are just ignoring it. And so they say things like, oh, well, there's side effects to the vaccine. Like everybody's talking about the myocarditis in kids, right?
Yeah, that's a new thing. Just for background, CDC came out yesterday and said that they're going to look at what looks like to be inflammation around the heart for those that have received the mRNA vaccine. We're still getting information exactly the target. It looks like the younger people that are getting it, although we should mention that inflammation overall has been a side effect of COVID-19 that has concerned physicians as well, not necessarily those that have just gotten the vaccine. It's something that we've seen in younger people, an inflammation response. I'm sure obviously, that it happens in older people. But I just want to point it out. It's not, you can get COVID and also have this too, right? Dr. Rutland, you could also get the vaccine, and they're saying a small, very small percentage of people are showing this potential side effect. Sorry, I just want to make sure everyone knew about that. So that's new.
That's what people have to understand is, listen, we are stimulating the inflammatory response. We're stimulating the immune system to do something. Nothing's perfect. If I go out in my car right now and I drive to the store, I could get in a fatal car accident. Does that mean that my wife's going to stop driving tomorrow? No, it doesn't. But there is a higher risk of that happening to me than me getting myocarditis after I got a vaccine. Shit happens. It's going to happen. Let's be practical here. You're going to hear about immunological consequences from stimulating the immune system. It happens. Everybody's protoplasm is different. Things happen. Things get created. I perfectly understand that. It doesn't mean you don't do those things. It doesn't mean you don't get the vaccine because, you're worried about the rare case of myocarditis. And I understand that it's a safety signal. I understand it, right? There are consequences of other vaccines as well, right? Your immune system can go a little haywire. It's not common by any stretch. Mm-hmm. And when you look at these cases, you also want to look in the general population to see, does this case rate, is it higher than the typical case rate of this in a specific population, right? I get that the CDC is looking at it and they should study it. And I understand that it can be a consequence, but most of the people, I think over 90% completely recovered. So it's a thing, but it's not a thing to be significantly worried about, especially when you have 216 cases and maybe 573 cases after the second dose and you have millions being vaccinated.
I do. Okay. So, but Elio Diva brings up this one question that has been asked, and it's the question of the moment, I think, for many, which is, and she says, in a typical flu season, doctors don't push vaccines on people who just had the flu. Mm-hmm. And so you get the flu, mm-hmm. You don't go out 2 weeks later, 3 weeks later, or even actually that flu season, mm-hmm. and get the flu vaccine. You just wouldn't do it. Mm-hmm. So
why did they push on it for SARS-CoV-2?
Why are we talking about it here?
Great question, because SARS-CoV-2 is so dangerous of an infection, right? And so people worry about it because we thought in Brazil they were getting reinfected even though these people were infected, but it turns out the data coming from there wasn't exactly true. So when you actually look at the data of reinfection rates of people who had SARS-CoV-2, they're not really getting reinfected. It's really, really rare.
What's happening then?
Rare. So what do you mean what's happening?
So if they're saying that they're getting reinfected, are they actually getting reinfected, or did they never get over the official infection?
No. They're actually getting reinfected. It can happen, really. The immune system, when you recognize the virus, all it is your body can now fight it better, and it can recognize the presence of it. But you can get infected 1 billion times over. You can be positive for infection. You just might not be in the hospital, which is the whole point, right? So it's like if you get influenza 1 year, you can get it the next year. Yeah, it changes the way it looks a little bit. But there's going to be antibodies and memory cells towards influenza in your body, but you can get reinfected. The immune system and immunity is not a force field. It's not like you close the door and you can't get reinfected. The way the immune system works.
But isn't that true about like measles or chickenpox that you does close that you don't you wouldn't you could get reinfected but you won't get symptoms?
What's shingles? Shingles is chickenpox for adults. It's the same. It's the same thing. So yeah, you can get reinfected. You're just less likely to have an immunological response to the infection. So you get chickenpox, and that's your immunological response to the presence of the varicella zoster virus, right? And then you might get exposed to it later on, but your immune system's like, oh yeah, I know this. I don't need to create all these vesicles all over your skin and make you look horrible and have scars on your face for the rest of your life. I'm just going to fight it, and we're good, right? And so that's all it is people have to understand that the presence of a pathogen leads to an immunological response, which causes the disease. It's not exactly the pathogen that's causing the disease.
So then Leanna has a follow-up question to this, which is she prefaces that she's not trying to be snarky, which I appreciate, Leanna. But I didn't take it as snarky. She said,
I didn't either.
The natural immune response you described sounds robust and diverse for those that have received COVID-19 or maybe who have been exposed and weren't symptomatic. For those who had a confirmed case of COVID, what is the added benefit of vaccine-obtained immunity?
Yeah.
How do you see that?
That's a great question. And practically speaking, it might be none. But the way that I look at it is like this. Once you've had SARS-CoV-2 infection, remember, your body is creating many different types of antibodies that recognize membranous, envelope, spike. So it doesn't create the diversity of the spike, which we know is the most important protein. So what I think should happen and what you'll see in the literature is once people are infected, they probably only need one shot of the vaccination, which means they might only need one shot of the mRNA vaccine of the spike because it's just going to increase the diversity of the spike protein they recognize. Let's take it a step further. People that have had SARS-CoV-2 infection may also have viral remnants, right, of the spike protein, of other viral proteins within their body. When you look specifically at the gastrointestinal tract, I think they looked at like 14 people that had SARS-CoV-2 and 7 out of the 14 had viral inclusions that were stained for and recognized in the GI tract, which is interesting because it just means the inflammatory response is still there and the virus's presence is still felt. So you have to wonder if that's contributing to some of the long hauler syndrome because you have these viral remnant particles that are left over. Most of the remnant particles are probably spike or nucleocapsid protein. And so then the question is, well, for people, and this is just anecdotal data for people in my clinic, I see a lot of long haulers, right? I see a lot of people that have significant inflammation after having the virus. And I tell them to get vaccinated. And when they get vaccinated, for some reason, a lot of their symptoms have improved. And it could be that your vaccine, the spike protein, is teaching the immune system how to recognize it and how to clear it. I don't know, but that's one of the theories behind it.
But is there a certain amount of time that you're waiting for someone to get that, like, if they're a long hauler, had they had the symptoms, let's say for 6 months, and then you're telling them, okay, let's try a dose of Pfizer, for example, or does that not matter to you as far as the timing between their actual infection and when they would later receive the vaccine?
Yeah. So
bless you.
Immunologically for me, I couldn't find a reason why patients had to wait 90 days. I'm just being honest. So like they say, you get the infection and then wait 90 days before you get the vaccine. I don't know where that 90 days came from. There's actually no literature to support that number. It's just, I know I have kids too. I get it. No. So for me, it's just like, I just allow the patient, I might wait a month, maybe 30 days or something to be like, okay, go get vaccinated. Immunologically, it just doesn't make sense. Like, yeah, you're going to respond really strong because your body's going to recognize the spike protein. Your body's going to be like, oh yeah, I've seen this, and ramp up the response, and you're going to feel like crap for like 24 hours. But then you're going to be over it, and you're going to have a more robust immune response to the virus. But that's what I tell patients. So I don't care if they get vaccinated within 30 days, whatever, it doesn't matter to me.
So another great question is, should people be doing an antibody test before they get a vaccine? If they had an infection or they were exposed and they have the antibodies, is there an urgency for them to also get vaccinated, or does it matter? Like, does that have any factor into what would be ideal?
It's a great question. I don't think people aren't getting reinfected at high rates, right? Even with variants that have had SARS-CoV-2 before. So if somebody doesn't want to get vaccinated and had the infection, I'm not going to sit there and scream and yell at you and tell you to get vaccinated. Right?
So do you feel, so let me ask you this.
Whatever.
Let me ask you this. Let's say that you didn't, you weren't vaccinated, right? You're just hanging out and you have friends coming over And one group of friends all had the vaccine. And one group of friends all had COVID. Do you feel safe?
Safe? Yeah.
Around both of them?
Yeah.
Equally?
Yeah.
Okay, because that's not the message that's necessarily coming from like health officials, because it's like the vaccinated people are super special and really protected and they're not going to spread this virus. But the people that had COVID, like, and I mean, that really is, I don't think, please tell me if you're seeing a different message, if you would like to write in right now. But that's the impression I'm getting. It's like we're developing these classes of people,
Doctors want to be right, and doctors want to make things black and white. Okay? They want it to be either black or white.
Right.
I got mixed kids. I married a white girl. So my world is very much in the middle. Okay? And so I am one of those people that's practical. And I like to sit practicality above any and everything else. And so from my perspective, if you have the infection, you're immune. And I'm cool with that. If you've had the vaccination, you're immune. And I'm cool with that. So for me, I don't care. I feel just as safe. Now, when you look at the literature and the data, everybody was worried about variants of concern, which I understand. But it doesn't look like the people who have had SARS-CoV-2 are getting these variants of concern at a high enough rate for me to be tripping.
Interesting. Okay.
So I'm practical, right? So I'm just real. I'm just being real.
Because really, you're right though. In the news too, it's the same thing. We're going to talk about vaccinated people, and we're going to talk about vaccine hesitancy, unvaccinated people, like these two groups. But like, there's a lot of nuance in those groups. Some people didn't even have access to the vaccine in a really long time, or someone had a COVID-19 infection and like doesn't want to run out and get it. It doesn't mean that they're anti-vax. It just means that like right now maybe they're not there yet. And it's like, that's the storyline. And if the true story about immunity in America for what's best for the nation needs to be more complicated, then I think the audience can handle a very nuanced conversation. And it's like, that's part of why I developed Smarter News, by the way, because I think nuance matters.
No, I do too. And I think practicality matters.
Yes.
And one of the reasons that I like to be on television and like to be on even Fox or, whatever, CNN, NBC, whatever, is because you have to have a practical human being, right? You can't, and I do have a TV show, Mother Monica. You can't, it's called Barbershop Medicine. It'll be out in late summer. Okay, so all right, this is kind of funny. So everybody watches Star Wars, right? There's a line in Star Wars where Ewan McGregor, Obi-Wan Kenobi, is fighting with Anakin Skywalker. And Anakin Skywalker says like this absolute statement, or this, like, you're either this or you're that. And he's like, only a Sith Lord speaks in absolutes. And I take that comment to heart, because there's no reason for anyone to speak in absolutes, because there is nothing that is absolute. Like, it's just not truth. And so that's why I like immunology so much, because it shows how the body is responding to certain things based on your genetic predisposition. And it can kind of go this way or that way or whatever. I was in a conversation with one of my friends who's like one of the smartest guys I know, Edward, who is deplatformed disease, great immunology communication. And he's kind of absolute. And he reads all the studies and all the papers, and he's very absolute. And, we were in a discussion, and he was like, hey, well, I told him, I said, listen, my long haulers lose their hair. And they have significant inflammation in their lung, and so I use immunosuppressants to calm down that inflammation, and their hair grows back. It's crazy. And I specifically mentioned a medicine called mycophenolate mofetil. And his response was, well, that's interesting. Mycophenolate mofetil inhibits cell division, and so it's weird that it works. And I'm like, it's not weird. It's just that it has more an effect on the immune system that's causing the inflammation of the lung and of their body than it does on the hair follicles that are growing back. Who cares? Like, that's just the way it is. So, again, it's not, they're nuanced answers that are completely necessary in this space. And the messaging for this entire space was awful from the very beginning. And the reason it was awful, honestly, was because it was created by physicians who work in absolute type of areas.
And to be so compassionate for what we all went through too, it was an emergency situation. And there are physicians that create health policy, and then there are physicians that treat patients, and they don't always think alike, and they're different. And developing health policy for a nation, we've seen is problematic. We've seen it problematic on a state level. We've seen different, this has been one of the stories of our times. And I think only now am I really even able to step back and digest what we've all been through over the last 16 months. Because it's calming down enough to allow that this was really scary. And we were trying to do that. And it still is a little bit scary sometimes. I mean, and that actually brings to another question. And I know I got to let you go. I love this is great. We're getting a lot of really amazing questions. So Midwestern White House was just asking about vaccinations for kids then, because of the lack of absolutes. We do know that these testings are happening when it comes to mRNA vaccines on those that are much younger than 12. She was asking specifically about should those be required for schools, and how we're approaching the conversation for the
Am I here? Yeah, I'm here.
Yes,
there was a great paper published literally a few hours ago, and I was reading it before I got on with you, and it actually addresses this question. It says the title of the paper is Community-Level Evidence for SARS-CoV-2 Vaccine Protection of Unvaccinated Individuals. In other words, in communities where you have adults getting the vaccination, are kids actually protected from infection, right?
Yeah.
So, and the answer is obviously, yes, right? So when you look at this paper here, I'll show you
I'm excited to read that paper. That's really interesting, because when I spoke to physicians at the beginning of this, when it was very new and last spring, while you're pulling that up, they were saying anecdotally what they were seeing is that kids were not bringing the infections home. It was the adults that were giving the infections to their kids. Okay, what am I looking at? I'm seeing.
So what you're looking at there is you can see people who are getting vaccinated, and then the percent of unvaccinated individuals getting infection and how it's coming down.
Okay.
So that's really what this graph is. I'll send you this paper. It's only 2 pages long, but it's cool.
So, and that's interesting. So does that mean that you're not going to be the first one to vaccinate your kids when you have young kids? They're under the age of 12.
My daughter wants to get vaccinated, so I'll let her get vaccinated. My 8-year-old.
Really?
Yeah, I don't care.
You think it's you're
Yeah, she'll be fine. She'll be fine. My other daughter will be fine. I have no genetic reason to believe that they're going to overreact to the presence of this antigen, whether it's an mRNA vaccine or an inactivated vaccine. But, did I care when they went back to school in person? No, I put them right back in school. Get your little asses back to school, go learn, because you got to learn. You don't need to be in the house all day long. This isn't party time every night. Go back to school. It's not prevalent enough in kids for me to really significantly worry about it. There are sad cases of children who have had it. There are sad cases of children who had a reaction to the vaccine, all expected in my mind. It sucks, but it's all expected in my mind.
Okay, so our people are asking for the paper. I'm actually getting a countdown, which means Instagram's going to cut us off from the live, and I'm not going to be able to save it. So
you want to save it and get back on, or do you want to?
Well, what does everyone want? What do you guys think? Do you have a couple more questions? We could definitely hop back on. And I'm going to have to put my son down for a nap in a second, but I still have some time. All right, here's what I'm going to do. I'm going to close the conversation. Why don't we jump back on for just 10 minutes for just the people that are here right now and answer any of their final questions, Dr. Rutland, because they've been, we've had a huge amount of people join us live for an hour, which is amazing. So I'm going to jump off, save this, make sure it posts correctly, and then we'll jump back on and answer their final questions. Does that sound good?
Yeah.
Okay. All right, guys. Thank you so much for all the questions. We're going to save this, post it so everyone can see it. And thank you, Dr. Rutland. All right, we'll be back in just a second.
Okay.